Welcome back to the Rebel Core Content Podcast. Core content for anyone, anywhere, and just in time. This is Swami. I'm here today with our in-house toxicologist, Dr. Sanjay Mohan. Sanjay, it's great to have you back after the summer.
How's it going, man? That summer went super quickly.
Way too fast.
I know. Hopefully our interns aren't as
Absolutely.
baby faced anymore, right?
Well, they are. And I'm realizing more and more that more and more of them are approaching being born after the year 2000. And that's very disturbing.
Yeah, I'm coming to a point in my career where my jokes are actually outdated, and I'm not that
Oh, it
old,
hurts, doesn't
Swami.
it? It hurts. You laughed at me when you were training with me and I made jokes about stuff that was outdated. Now you're there. It's not so funny on the other side.
No, it's terrible, actually.
All right, well, let's get into our content today because we do have a great topic, one that I think is complicated and nuanced, and in some ways, it perfectly communicates what we do in emergency medicine. It's a can't miss diagnosis, which is ingestion of a toxic alcohol. These are very tricky cases to catch, to know who to send labs on, what those labs mean. We're going to get into all of that. But I want to start with the absolute basics as to what defines a toxic alcohol.
Right. So I often say that statistically and epidemiologically speaking, ethanol or your run-of-the-mill alcohol is probably the most toxic alcohol there is. And we know that as ER doctors. Ethanol poses a tremendous burden on our world: intoxication, related physical and psychiatric trauma, and ethanol withdrawal. Colloquially, though, when people use the term quote unquote toxic alcohols, they often are referring to methanol, ethylene glycol, and sometimes isopropyl alcohol. Methanol is commonly found in windshield wiper fluid, solid cooking fuel, and historically moonshine. Ethylene glycol is a component of radiator antifreeze.
Why are those alcohols considered toxic versus ethanol?
So, in addition to their propensity to cause a significant degree of intoxication, toxic alcohols lead to end organ damage by way of renal dysfunction, optic neuropathy, and life threatening acidemia and metabolic disturbance.
All right, let's start with a little bit of pathophysiology review. How are alcohols metabolized?
So, using the same enzymes found in ethanol metabolism, methanol is metabolized to formic acid, and ethylene glycol is metabolized primarily to oxalic acid. The presence of the parent alcohols, so methanol and ethylene glycol, will contribute to something called an osmolarity gap, whereas the toxic metabolites, formic acid and oxalic acid, will contribute to end organ damage and an anion gap metabolic acidosis.
All of that is going to be really important. I mean, we don't do a lot of pathophysiology on the podcast, but in this case, understanding those two things that you said, the parent alcohols contribute to the osmolarity gap. The toxic metabolites contribute to the metabolic acidosis, the anion gap metabolic acidosis. That's really important to understand as the parent alcohol is metabolized in the patient's system. We're going to come back to that in a minute. Before we go there, I want to talk about presentation. We see a lot of intoxicated patients. So, what's going to differentiate the ethanol intoxicated patient from the toxic alcohol intoxicated patient?
So, this is really the crux of the issue, Swami. Shortly after ingestion, all alcohols induce intoxication and inebriation, which means clinically, shortly after a toxic alcohol ingestion, patients look the exact same as if they drank run of the mill ethanol. That's what makes this diagnosis so difficult. With time, as that parent alcohol gets metabolized, the generation of toxic metabolites leads to an anion gap metabolic acidosis and specific end organ damage. Specifically, methanol's toxic metabolite, formic acid, leads to an optic neuropathy, which ultimately leads to a wide range of visual complaints: blurred vision, your classic quote unquote snowfield vision, or complete blindness. In contrast, the downstream metabolite of ethylene glycol, oxalic acid, complexes with calcium to precipitate crystals in the renal tubule and thus creates nephrotoxicity.
And the first thing you mentioned right up front, that all of these alcohols cause the same intoxication picture. That's why patients drink these compounds. They drink them because it still makes them intoxicated, which is what people are seeking often. Now, some patients are coming in with a suicide attempt from drinking one of these, but most of the patients that I've seen were trying to get quote unquote drunk, and that's what they had access to. That's how this sometimes happens. So we just have to understand that it is difficult to tease these things apart because the presentation can be very similar, but we want to try and catch them early. And we'll talk about why in a moment, but catching them early means that we can intervene before you get the toxic metabolites in their system. So this is where it's really tricky, Sanjay. It would be great if we look at the patient, we're like, oh, That intoxicated patient clearly used methanol, and now I can start the antidote. But that's just not the situation that we're going to have. We can ask the patient, and some patients will tell you. If you ask them, what did you drink? And they're like, I drank windshield wiper fluid. You're like, oh, all right. Well, then I know what's going on here. Or they say, I drank some moonshine that I cooked up in my bathtub. If you're in the 1920s, maybe that's where you're going to get your hint. But sometimes you don't get it from the history. So, what can we do to try to tease these things apart, to try to make this diagnosis on the early side?
So I wish there was an easy answer to this, Swami, but I try to place my patients in buckets just to make my life easier. As you just alluded to, the patient that says, hey, I drank methanol, I drank ethylene glycol, you clearly have to work that patient up. Those are, in fact, probably your easiest patients. Otherwise, if you have that intoxicated patient that just looks terrible or is not metabolizing appropriately, take a step back, go back to your history and physical, and maybe get blood work on that patient. Alternatively, if you get blood work on that inebriated patient and there's a tremendous degree of metabolic disturbance, acidemia, or renal failure, then the toxic alcohol ingestion has to be on your differential.
So, if we have an intoxicated patient in front of us, our spidey senses going off, telling us that this isn't straightforward. Now we're going to get labs, but it's not just get labs, right? We want to be very specific. What labs do we want to obtain in this patient?
So once a decision has been made to evaluate for a toxic alcohol ingestion, the following labs should be drawn: a serum chemistry, venous blood gas, ethanol concentration, and serum osms, which naturally begs the question, Swami, what the hell is an osm? And I
It's a
can
good
tell you,
question. I'm not really sure. If someone asked me, what's an osmo, I'd be like, I don't know. It's an osmo.
honestly, I'm technically a toxicologist and I still have difficulty with this. But the way I frame this is that an osm or an osmol is really a unit of measurement for an osmotically active compound. So the way I frame it, osms are how much stuff is in solution, typically 1 liter. So keeping in mind that the measurement of toxic alcohols are readily not available in most emergency departments, we use something called the osmolar gap instead. Now, the osmolar gap is a surrogate tool used to detect the presence of toxic alcohols before they have been metabolized. It is the difference between your measured osms, which is a test you need to order from the lab, and calculated osms, which is something that you need to manually calculate. And by manually calculate, I usually mean go online, go to MDCalc, and we'll figure it out. So the formula, which is important to remember for calculated osms, is 2 times the sodium plus glucose over 18, BUN over 2.8, plus ethanol over 4.6. Now remember, shortly after ingestion, the parent alcohol is present. The parent alcohol being methanol and ethylene glycol. This is what contributes to the osmolar gap. So in theory, shortly after presentation, patients should have an elevated osmolar gap.
Along with that, if they have a big osmolar gap, then they're going to have little to no anion gap. Those are kind of the things that we pair together. And I remember seeing this kind of graph that graphs osmolar gap versus the anion gap. And as the osmolar gap starts high early in ingestion, and the anion gap is low early in ingestion. And as the patient metabolizes, the osmolar gap falls and the anion gap climbs. And that can kind of tell you a little bit of an idea of how long it's been since the patient ingested whatever it is. That gives you that information. And that osmolar gap is really the things that we're not measuring. I mean, you could send a methanol and an ethylene glycol level. From what I remember, those are not done in house. You're not going to get those back in anytime soon. So that's what the gap is. It's filled by those toxic alcohols. It means that we have to know what a normal gap is, because there is always a little bit of a gap. There's always some stuff that we don't measure, we can't measure, we don't have a test for. So what's a normal gap? So I have someone who comes in, they just use ethylene glycol, or they tell me that they drank it a little while ago. I get the measured osms. I calculate the osms from my labs. What gap am I expecting to see that's normal versus an elevated gap?
Yeah, so strictly speaking, a quote unquote normal osmolar gap is anywhere between a negative 14 to 10 osms. As you said, the osm gap is imprecise, it's poorly sensitive, and it's poorly specific, meaning that if you're just critically ill, you're probably going to have an elevated osmolar gap. So this is not a test that you should be routinely sending in all your intoxicated patients, as it's incredibly messy. Remember, a normal osm gap does not rule out a toxic alcohol ingestion. As you said, Swami, if you present early, you may have an osm gap. If you present late, you may have an anion gap. But as with everything else in medicine, our patients don't read the textbooks, which mean they present somewhere in this weird middle ground, and it's hard to decipher. And I know I've been beating a dead horse ever since I've been here, but please call your local poison control center or your local toxicologist to help you with this evaluation.
We had similar people who trained both of us. I know you did a dedicated tox fellowship. I did not, but one of the things I remember people talking about again with that graph is if you happen to get them at the right time, they have neither an osmolar gap nor do they have a significant anion gap. And especially because there's a little bit of that wiggle room between -14 and 10. So you might get the labs and find absolutely nothing. And that really underscores the need to be suspicious. And once you think that it's going on, don't rely on the labs to give you the answer. Involve your toxicologist, get help. This is a great place to look for that. One of the things that we haven't really been explicit about, and you've mentioned it a couple of times, but I want to be really clear, is that we are not saying to get all of these labs on every patient who comes in intoxicated. You're only going to get them where you have a suspicion. You have a suspicion for one of these agents to be on board, because I'm pretty sure, Sanjay, from the places that you and I work, if we got this set of labs on every patient who came in intoxicated, we would, between the two of us, bankrupt the entire system within a couple of weeks.
Oh, 100%. And the way I analogize this is that you wouldn't get a dimer on every patient coming into the ER with, chest pain or shortness of breath. This is about risk stratification and your index of suspicion. So if you have a high index of suspicion, sure, 100% get that awesome. But otherwise, it's messy and imprecise and may lead you down the wrong path.
A lot of people that I've talked to have caught these ingestions a little bit later on. They didn't get the history from the patient, or the patient wasn't forthcoming with the history of ingesting one of these agents, but then the patient doesn't clear. They don't look good. One of the things that I often see is the patient is just tachypnic and they're like, oh, that patient's breathing really fast. That's not great. What will the patient look like later in this intoxication? Now, we talked about how they'll have an anion gap, but what's the patient themselves going to look like that should be like, ooh, maybe I missed this?
Right. And you kind of just alluded to this, Swami. Tachypnea and Kussmaul breathing is never good, really, in medicine. But in the context of intoxication, you should be thinking about life-threatening acidemia. As we know, both methanol and ethylene glycol will lead to acidemia to such an extent that you're just trying to breathe off that CO2 as fast as you can to compensate. Moreover, if they're objectively complaining of, visual deficits, well, then your index of suspicion should be higher.
All right. So we have worked up the patient. We've evaluated them. We're worried about this. We get the labs back. It shows an osmolar gap, or maybe even it's a little bit later and we see an anion gap. How are we going to treat the patient?
So if the clinical presentation and labs are concerning for an ingestion, fomepizole should be administered at a loading dose of 15 milligrams per kilogram intravenously. Fomepizole inhibits alcohol dehydrogenase, which prevents the parent alcohol from being processed into its toxic metabolite. Remember, fomepizole just buys you time. It doesn't actually treat what's going on. You still need to get that toxic alcohol out of your body. Generally, in today's world, nephrology should be consulted for hemodialysis, as toxic alcohols can be removed extracorporeally. Moreover, vitamin supplementation will help divert metabolism away from toxic end products to more benign metabolites, specifically folate for methanol ingestion and thiamine and pyridoxine for ethylene glycol ingestions.
I'm going to be honest with you. When I've suspected these, I've just given all the vitamins. I'm like, I can't remember which one goes through the which. And yes, I called the toxicologist and all that stuff, but I just gave folic acid and I gave thiamine and I gave pyridoxine. I'm like, everybody can use a little bit of extra vitamins. It's not the biggest deal in the world, but getting that fomepizole on board, getting your toxicologist on board, getting your nephrologist on board, all of these things are really important. And like you said, the fomepizole buys you time. Honestly, what it really does is buys the nephrologist time, because it means that instead of them coming in at 2 in the morning or, midnight, they can usually wait and then dialyze that patient at 6, 7 o'clock in the morning. But I wouldn't wait for 6, 7 o'clock in the morning, especially if the patient already has a significant acidosis. Remember, acidemia in and of itself is an indication to call nephrology for possible dialysis. So I just get them on board right away. Some of the nephrologists will be like, yep, start the fomepizole, follow the patient. If they're getting worse, call us back. We'll come in and dialyze early. Otherwise, we'll see you guys at 7 in the morning and we'll dialyze them at that time. And I think that's a fine approach. I don't really want to drag anybody in unless I absolutely have to. And Sanjay, let's be honest, nephrologists are really smart, but then they're going to come at me with big words and complicated concepts, and I can't deal with that in 3 in the morning. So I'd rather that they wait, come in at 7 when I'm going home. They can take the patient for dialysis, but just get them involved early, I think, is really the key here. And I got a question on fomepizole. If the patient comes in early, we see the osmolar gap, we start fomepizole, that totally makes sense to me. If the patient already has a significant anion gap after ingestion, does fomepizole play a role? Is there still a benefit to giving that patient fomepizole if they've already metabolized a significant portion of that toxic alcohol?
So that's a great question, Swami, but we never really know how much they've metabolized, right? At a certain point, sure, they may have toxic end products, but the parent compound might still be around. So other than the cost of fomepizole, I think it's a low risk, high reward situation where I would just give it to them.
Yeah, I think that makes a lot of sense, especially because you don't know, has this patient been drinking ethylene glycol for the last 8 hours? And so I'm seeing an anion gap, but they actually do have some fresh ethylene glycol in their system as well. Like you said, patients don't read the textbook. It's not always single ingestion. It is often a prolonged ingestion before they get to you. So without having that exact knowledge and the fact that you're never going to get it, you're better off pulling the trigger, giving this medication. And fomepizole doesn't really have a lot of contraindications. It doesn't have a ton of side effects. It's a relatively, in terms of all the things that we do, a relatively safe medication if you make a mistake and give it where it isn't indicated.
Totally. Other than cost, there's really no downside.
All right, Sanjay, before we wrap up, can you give us a couple of big take home points on toxic alcohols?
Toxic alcohols, generally referred to methanol and ethylene glycol, as these substances pose significant metabolic derangement and end organ damage. Patients who present shortly after ingestion will simply look inebriated, no different than ethanol. At this point, patients will have an elevated osmolar gap and little to no anion gap. Patients who present in a delayed fashion after ingestion may have a normal osmolar gap, however, will manifest the signs of end organ damage, anion gap metabolic acidosis, visual impairment, or renal dysfunction. The osmolar gap is poorly sensitive and poorly specific as a surrogate measure that is used to detect the presence of toxic alcohols. A normal osm gap does not rule out a toxic alcohol ingestion. And lastly, management includes fomepizole, hemodialysis, and vitamin supplementation.
Excellent. Well, that's all for the Rebel Core Content podcast this week. We'll be back in 2 weeks, another cast. In the meantime, don't forget to pop on over the site, see all of the fantastic posts from our faculty. And until next time, stay safe.